So we're working with a rotator cuff situation. This is our third session of the vibrational release therapy on the rotator cuff. And when we began, pain was very severe. How did you characterize it? 8 or 10 out of 10? It was really...
Yeah, it was about a 9.
About a 9. Okay. And unable to lift above about here in the front or here to the side. So let's just see where you're at right now. Pretty good. And where do you feel it when you get to the end of your range of motion in that?
It's right here.
Right, okay. And go ahead and come up as high as you can. And then, can you put one finger on the spot, or maybe I can help?
Right here.
Okay, so this is pretty much the mid-deltoid insertion. And then, how about when you go to the side?
Same spot.
Same spot,
Right here.
and a little bit toward the front, toward the bicep tendon,
Yeah, down on it.
and it kind of extends into this area, the pain does. And then reaching behind you, which that was the really bad part
Yeah.
when we began, and you can really go a lot better now.
That's as far as I can go, and it shoots down the arm.
And this is more in the bicep tendon area. So let's go ahead and begin. And on all of this work, we're going to keep the plane of the PainEraser parallel to the surface that we're working on. So we're not going to dig an edge in and risk irritating anything. So let's have you try to relax the shoulder. And
That hurts right there.
hard to get above
I
that
can't
level,
get that, yeah.
but we can here.
Right
It's
there,
actually
yeah.
pretty good there. And let's have you go back,
That's as far as I can go.
and you feel it more in the front here,
Yeah,
right?
it's all on
So while you're in that position though, let's try to release it. Let's see what those motions look like now. Try going up. Is that a little freer?
a little bit freer.
And then try going to the side. Oh, that looks quite a bit
little
freer.
bit, yeah.
Yeah. And then behind you? A few more degrees that way too. Okay. So, let's do a bit more work. And one of the things that I'm looking at here is the possibility that because of the length of time that you've not been able to use your shoulder,
Yeah.
that there's been kind of a contraction of the capsule. And that may require some hanging at home where you reach up to the top of a door, or
Okay.
you slip a belt over a door and then you hold on to the belt, and then you kind of bend your knees
Go down.
and use your weight to stretch out that capsule. Because that's what happens with ligaments and tendons. They just, with disuse, they tend to get a little shorter and a little shorter. And once you've had a few months of that,
Yeah.
then you have to kind of slowly stretch it out. But working on these muscles will make it comfortable enough that you'll be able to do that. So let's do a little more work on these muscles. Want to reach behind you? And then as I'm working here in front, try to go just a little further and a little further over with your hand.
Okay.
trying to rest your arm here if you can.
It's so hard, but right there it hurts.
Yeah.
It already hurts, okay.
Can you try to release a bit of that elevation? Let's see that lateral movement. Not too bad. And how about going behind you? That's a lot better.
Yeah.
Yeah. Well, that's almost normal. And then in front. And that's pretty unrestricted. So a lot better. So the homework, I think, is going to be to use a belt over the corner of a door or something, and just a traction, because eventually you got to get to the point that you can get up like this freely, and that's just going to take a little work to stretch that out. And we'll keep doing the PainEraser release on the muscles when you get back from your trip.
Okay.
Okay.
Sounds good.
Very good. Thank you. In this video, we're going to discuss the use of the PainEraser for releasing tightness and pain in muscles and soft tissues of the body. We want to talk a little bit about the kind of instrument or tool that you're going to be getting to power the PainEraser. And that's going to be a multi-tool. A multi-tool is a shop tool that's made by a number of different manufacturers, and it oscillates like this. If you were to see the movement of the head, you see this oscillation of 2 to 3.5 degrees depending on the manufacturer of the tool. The frequency is somewhere in the neighborhood of 0 to 20,000 oscillations per minute. Again, depending on the tool and depending on whether it's a variable speed. The professional tools that are standalone tools made to do this kind of vibrational release typically run in the neighborhood of 10,000 cycles per minute. So there is perhaps an advantage to having a variable speed tool that allows you to go below or above that particular speed. Most of the time with the Makita, I use it in the settings 2 to 3 range, and that's in the neighborhood of about 9,000 to 13,000 oscillations per minute, and that works awfully well. There are two types of tools. One that has a spring-loaded clamp and allows you to release this way, and the other that has an Allen screw here that accepts a hex wrench and allows you to tighten the instrument. And so it would slip on in this fashion, and you would simply screw it down tight. I want to show you using one of the multi-tools where we've removed the protective shroud, and you'll see that as I place the multi-tool in position, that the washer between the screw and the multi-tool covers a significant area around the arbor of the multi-tool. That's important to securely hold the device. For some manufacturers, what you'll see, this is true of the Dremel, is that the mandrel is the name of this stem that secures the multi-tool, that it's very small and it doesn't grab very much of the metal of the PainEraser. And in this situation, what you'll want to do is use a fender washer that has an opening in the center of 1/4 inch and has a diameter of 1 inch. And if you happen to have a tool that has a very small mandrel, what you can do then is place the washer between the screw and the tang of the PainEraser, the metal part of the PainEraser. That gives you a larger surface area, and then you can simply screw it down in this way. The same thing can be done if you were to have one of these toolless devices that have the spring-loaded clamp. In this case, we don't need to do that because the Makita has such a large mandrel, but if we had one that had a very small mandrel, we might consider doing this, sliding the PainEraser on like that, oops, like that, and then securing it in this way. The other considerations for the PainEraser are sound. And multi-tools operate at such a high frequency that there's a lot of vibration. In the cordless multi-tools, you'll find that there's more sound because the tool has to be designed loose enough that the battery can be slid on and off. And that means that when you're operating it, it's going to be kind of loud. The other thing that we want to point out is that if you have this type of tool that uses an Allen wrench to tighten the mandrel, then what you'll do is simply position the multi-tool like this, hold it in place, and then use the Allen wrench to tighten the screw and make sure that it's tightened good and tight. If it's loose, it's going to be a lot noisier and it could damage the instrument. So just make sure that when you put it together, that you put it together nice and securely. I'm going to invite one of my patients, Esther, to come join us, and she's going to help us demonstrate how the PainEraser is used. So, Esther, thanks. You know, I was looking today, you're patient number 70. We're currently at about patient number 10,000. So, you and I have been working together on these various things that come up for people for over 30 years.
Yes, I've been back here for 33.
33 years.
So it was soon after I moved here.
Right.
Yeah.
So let's have you lay face down, and we'll demonstrate a little bit some of the general considerations about using the PainEraser. A couple of things. Remember, the motion that the PainEraser does is going to be this oscillation. And one of the things that we want to consider is that when we're working with somebody, that we may want to change the orientation of the PainEraser, the axis of the PainEraser now transverse to the body. We may want to change it 90 degrees. And so typically, as I'm working, what you'll see is that in order to get a really complete release of the tissues, I'll do a combination of about 50% in one direction, 50% in the other direction, using very much the same strokes of the instrument as I move it over the body, but changing the orientation so that we are able to release all the adhesions, all the tightness in those tissues and muscles. The other thing to consider is the tilt of the instrument. So let's consider the tilt in this way. If we're moving, let's say, from inferior to superior, if I tilt the leading edge of the instrument down, it more aggressively strikes the tissues. If I have the instrument parallel to the tissue and I keep it parallel as I'm moving over the tissues, then there's this planar oscillation, but there's no dipping into the tissues, and this may be much more comfortable. And if I slightly tilt the instrument upward, what we'll see is that it glides very easily across the tissues, and this too is a preferred way of holding the instrument. When you get some experience using this, you may find that there are particular areas or particular situations where you want a little bit more aggressive kind of action, and you'll tilt downward just a little. You'll never use the instrument like this because that would be kind of a pounding force and insulting to the tissues. Another thing to consider is using this on bare skin or over clothing. And if you're using this over bare skin that's dry, you'll find that the instrument moves very easily. If the skin is a little bit sweaty or clammy, you'll find that it doesn't glide as easily. And you might want to have the patient be sure to wear some thin garment like this, some sort of a knit garment works very well, or something like a shirt or loose pants, so that you can work the tissues very easily and glide the instrument freely. If you're using this over very heavy clothing, like jeans or a jacket or something like that, there are two issues. One of them is that the friction, the shear stress that we're trying to deliver into the tissues through the skin is going to be lost in those layers of clothing. And the other thing to consider too is that if you're using this device over very rough clothing like jeans or some jackets, over a period of time there's going to be an abrasion that occurs that wears out the head of the instrument a little more quickly than it would otherwise. So those are some general considerations. Other general considerations are this, that we always want to work according to patient tolerance, and although occasionally some areas that we work on may be a bit sore, that this work really should never be painful. to the patient, the PainEraser is going to feel like kind of a tickle. In fact, little kids enjoy this. They laugh typically while they're being treated. When you're working on areas that really need it, where there's a lot of adhesion, particularly, let's say, in this area, we may find that the tickle is so profound that a person almost wants to pull away from it. And as the conditions of the tissues improve with the use of the PainEraser, we'll see that that goes away very, very quickly. We want to avoid using the PainEraser on any area where massage would be contraindicated. And this basically is any area of diseased tissue. So we would never use the PainEraser or any other kind of massage on an area where there was an open wound, where there was infection, where there was a cancerous tumor. We wouldn't want to use it on an area of acute injury. Let's say a muscle strain that's very fresh, there's going to be a disruption of the capillary beds and tearing of fibers. And so typically, massage on an acutely injured area would wait until those tissues have healed for a bit, perhaps a week or so. And so with those precautions, we want to go ahead and demonstrate the use of the PainEraser. So Esther, let me ask you to sit up, and we'll start at the top and we'll work our way down, and we'll go through the whole anatomy and discuss a number of ways that the PainEraser might be used. The head is an area that we want to consider using the PainEraser. Many people have chronic headaches, facial pain, and the pain TMJ problems. And the PainEraser may be very helpful. Consider this, that if we could see underneath the skin of the scalp and the face, we would see that almost the whole area of skin covers muscle. Frontalis muscle here, the temporal muscles here, suboccipital muscles behind, muscles of the jaw here, muscles of facial expression in this area, and all of those are areas that we may want to work on. One of the things that we'll be very careful about are the eyes. And so I recommend, if you're working on the face, that you have the patient bring a pair of, or you have a pair of sunglasses that they can wear. And this is going to keep you away from the eyeball itself. That's not an area that we ever want to use the PainEraser on. In this area, where people often hold tension, you see people kind of scowling sometimes, and this is an area where that chronic tension in these muscles of the brow may produce head pain. And in this area, we'll be very careful to use the lightest of pressure, just barely making contact with the scalp, with the forehead, and we'll be working like this, we'll be working like this, and this will be very, very gentle. Let's turn your head this way. And you can go ahead and slip those glasses off if you like. And it'll be a little easier to see here. The large temporalis muscle is a muscle that moves the jaw. Many people hold tension in the jaw. Many people brux or clench their teeth at night. And consequently, this muscle can become chronically very tight and very sore. So this is an area where we often use the PainEraser up into the scalp, on the parietal side of the head, moving back and forth. Changing our angle by 90 degrees so that we get a more complete release. And covering this whole side of the head, all the way to behind the ears. Let's have you turn all the way around, Esther. The suboccipital area is another area where there tends to be the accumulation of muscle tension and stress. And this is an area where we'll work across the base of the skull all the way from this area underneath the ear where you find the projection of bone called the mastoid process, from one side to the other. And we can work the whole neck all the way down to the cervico-dorsal junction here in this position. We may want to turn the instrument in this way and work this lateral web of muscles that includes the scalenes. The shoulders are a very common area of injury and overuse, particularly the rotator cuff. And this group of muscles originates on the shoulder blade and comes over to the humerus, attaching here at the greater tubercle. These muscles do primarily external rotation, like this, and they're often the subject of overuse. So we'll just ask Esther to hold to her other shoulder, and I'll come over here with my left hand and just support her arm a bit. And in this region, go ahead and relax that shoulder down a little if you can. We're going to work in a fan-like array because that's the positioning of these muscles. We have a web of muscles that attach here, fan out above this ridge of bone on the shoulder blade, below it, and to the lateral margin. And so in working on the rotator cuff, we'll come in this way, the lateral edge of the shoulder blade all the way up to the attachment here in the humerus, and we'll come down and out and over the top. And again, we'll change the orientation of the device so we get the most complete release possible. We may also go down into this area where the shoulder blade is connected to the spine itself. Esther, let's have you turn the other way, if you would. Always when we're working on the shoulder girdle, the rotator cuff, we'll be taking a look at this bicipital area. And this will typically be very tender over the bicep tendon, and this is an area that we'll work on in this position with the arm externally rotated a bit, working up in this way, a little bit over into the pectoral muscles, a little bit over into the lateral aspect of that bicep tendon, and even over here into the deltoid attachments on the shoulder cap. We'll change the orientation of the PainEraser to get a more complete release. And that will be a fairly complete release of the shoulder area. One of the things to consider on the lower arm is the anatomy of the forearm. And there are muscles in the forearm that do this and flex the wrist this way. Those are the big muscles that attach on the inside of the elbow. And there are muscles that do this and pull the wrist backwards, and they attach on the outside of the forearm. So in working these areas, again, we'll be up in the region of attachment to the humerus, and we'll go all the way down here to the wrist area and the back side of the forearm, working these radial extensors, as they're called. And changing the orientation of the device to get a more complete release. There may be areas up here where we'll turn the device over And we'll actually use this smaller head, perhaps in this area here, being careful not to use much pressure, letting the device do the work. With the ulnar flexors, those on the medial side of the forearm, again, we'll work up in this area where they attach into the humerus. We'll work the muscle belly that's on the anterior part of the forearm, and we'll go all the way down to the tendinous attachments at the wrist. We'll change the orientation of the device for about 50% of our treatment time, so we get the most complete release. And again, we may want to turn the device over and use it in a little more particular way to get into those attachment areas of these tendons. The bicep is another muscle we might work on. The bicep tends to attach here in the more medial aspect of the forearm, and so we may just work in this manner on the lower bicep, and perhaps to turn the device over to get a little more specifically into the attachments of the bicep into the forearm. There will be conditions in the hand that we'll want to consider. One of those is carpal tunnel. And carpal tunnel is a situation where the connective tissues over the top of the tunnel that conducts the artery, vein, lymphatics, and nerve in the hand becomes very tight and restricted. And in this situation, we'll be using the PainEraser in this manner. Changing the orientation of the device occasionally to get a more complete release. And we may want to use the smaller head to get a little more specifically into these areas of the carpal tunnel and perhaps into the ligament that covers the carpal tunnel itself. Anytime that we're working on a hand or a foot, we're working on a structure that's very bony. There isn't a great deal of padding like there might be, let's say, in the shoulder area or the thigh. And so, again, we might use the small head to work on some of the muscles like the lumbar pals between the bones of the fingers, but we'll be very, very careful, very, very light, and we won't use this for more than about a minute to cover the whole back of the hand. So this is a position where obviously we'll be doing a lot of our work just because it gives us access to a whole lot of the anatomy of the back and the hips and the legs. So in this area, we can work from the suboccipital area of the neck all the way down into the shoulders. We can work on some of the rotator cuff areas that we talked about earlier in a sitting position. And we can work on this web of muscles that go from the shoulder blades to the cervical and the dorsal spine all the way down to this area. So we have kind of a V-shaped structure here and here where these muscles and fascial structures come up and attach into the shoulder blades on both sides, and it's an area where people hold a lot of tension. Additionally, there's a very large web of connective tissue, fascia, in this lumbodorsal area, and this is a major stabilizer of the low back. It's also an area where there's tends to be the holding of a lot of tension, and this area is an area where you can give a patient quite a bit of relief by paying attention to adhesions and tightness that you can release here. So as we're working in the cervical area, we'll use perhaps a rocking motion as we go back and forth over the neck itself. We can work the scalene muscles on the side of the neck in this manner. And we can work the parascapular muscles spine and the shoulder blade, and those between those muscles of the rotator cuff between the shoulder blade and the humerus, like this. As we get down to the lumbodorsal area, we're going to be covering this region from the lower ribs to the top of the crest of the ilium, or the hip bone. And to do that, we'll be working in this manner. We'll change the orientation of the device so that we get the most complete release of adhesion and tightness possible. When we get down into this area, the bottom of the lumbar spine, we want to pay attention to certain anatomical landmarks. So if we go over here and feel for the top of the crest of the hip, and we go straight across to the spine, we'll be at the fourth lumbar. And we drop down one bump in the center line, and we're at the fifth lumbar. Fifth lumbar is the bottom of the spine. It attaches to the sacrum below, and there's a ligament from the fifth lumbar on the left and right that go out to the iliac crest. That's called the iliolumbar ligament, and it's a common area of pain. This is an area that we'll want to focus on. One of the things that you'll notice because of the shape of the PainEraser is that when we're completely flat, we have a relatively large area of contact. If I lift the back end of the PainEraser, it brings the pressure more to this point, and it makes for a little more specific kind of a contact. So we may do that in this region, working on the iliolumbar ligament. We may also turn the instrument over and very lightly use this close to the spinous processes of the midline to release those very small muscles of the lumbar spine. Now, as we get into the pelvis, we want to think about this triangular bone, the sacrum, that supports the lumbar spine, and the fact that the sacrum makes two joints, one on the left and one on the right, with the pelvis. And that's where the sacrum meets the ilium. So this is the sacroiliac joint that you hear about, and it's an area where a lot of people have troubles, and it's also an area where the largest ligaments of the body are to be found. That's because this is the biggest joint of the body, and it transmits the biggest forces from the spine to the legs and the legs to the spine. So on either side here we have very large ligaments, posterior and lumbosacral ligaments, and near the bottom of the sacrum we have what's called the sacrotuberous ligament, and you'll notice that kind of going out at an angle from the tailbone to the ischial tuberosity, or the sitting bone, is a large ligament that will feel like a cable, maybe half an inch around, that you'll feel underneath your fingers as you take a look at the anatomy here. And so this is an area where we're going to be using the PainEraser quite commonly on the posterior sacroiliac ligaments, on the left and the right, changing our orientation to get a complete release. And then down into this area where we have the sacrotuberous ligament. And some of these descriptions may sound a little unfamiliar to you, but I just suggest that you get online, go to Google, type in ligaments and muscles of the pelvis, and go to images, and you'll see some really good documentation of the anatomy that you're working on. And so any area that you're unfamiliar with, that's a great way to get familiar with it. Now, I'm going to ask you to lay on your right side, Esther, and we'll take a look at the lateral aspect of the hips and pelvis and the leg. So the anatomy that we want to pay attention to here is this big bump that everyone has on the side of the hip. And this big bump is called the greater trochanter, and it's a big bump because it's a point of attachment for a whole lot of muscles. The muscles that go up and to the side from this point are the gluteal muscles, the most forward of which is the gluteus minimus, the gluteus medius, and then the big gluteus maximus back here. There's one more muscle. It's not a gluteal muscle. This one is called the tensor fasciae lata. It's a small muscle that goes from this anterior part of the crest of the ilium to the iliotibial band, which is a big belt-like tendon that goes from the hip to the knee and is a lateral stabilizer. So this tensor fasciae lata allows the body to tighten or loosen the tension along this whole tendon. So this is an area that we'll very commonly work on for people with complaints in the legs, in the hips, in the low back. And the way we're going to use this is in this way. Starting here with the greater trochanter, we'll go out in a radial-like manner to get all of these gluteal muscles and the tensor fasciae lata. So we'll even go here a little bit anteriorly. We'll change our orientation to get a complete release. And we'll go all the way back to the sacroiliac ligaments that we were working on in the face down position. The iliotibial band will be working in this manner. Clothing like these tights works really well with the PainEraser. And so this is the style that we'll be using to release these tissues. Esther's an athlete. She's very trim. Not everybody's going to be like this. You're going to find people that have quite a bit of fat in this area. And this is an area that's very important to release. In doing that, for somebody who's obese, you're not going to be able to slide this and to create the proper tension of the instrument against the tissues. So what you'll want to do is, in this situation, use enough pressure to displace that fat a little bit so you can get down to the bone, so you can get down to the tendon and muscle structures. And since you can't slide freely, since you're pressing into that fatty tissue, what you'll do is rock this instrument and you'll kind of walk it in this manner in order to work those tissues well. And this is going to be pretty comfortable for the patient, and it's just a little different style of using the instrument that you'll need for some of your patients. Okay, so Esther, let me ask you to lay face up if you would, and we'll continue with the legs. The muscles that we were just looking at in the pelvis that attach to that greater trochanter are the external rotators of the hip. There are internal rotators of the hip, and to get to those, we'll ask the patient typically to make kind of a figure 4 position with the leg. And here, what we'll be doing is working on the muscles that attach to the lesser trochanter, and that's pretty much straight through this area. There is also the inguinal ligament that goes from the anterior superior iliac spine, this point that you find in the front of the hip, and it goes down to the pubic bone. So this ligament, the inguinal ligament, is the attachment point for a number of soft tissue structures in the pelvis. And so we'll typically be working this area in this way to get as much of the attachments of the musculature of the upper thigh as we can, and also some of these ligament structures in the front of the pelvis. And we'll again be rotating the angle of the PainEraser in order to get the most complete release that we can. One of the muscles that you want to pay attention to is the reflected head of the rectus femoris. The rectus femoris is the extensor muscle right in the middle of the front of the thigh. And it has a small reflected head that goes up into the hip and is often a cause of pain. And so we want to pay attention to that, working that area with the PainEraser in this way. The rest of the thigh, whether we're in the front or the back of the thigh, whether we're working with the hamstrings in the back of the thigh that flex the knee, or the quadratus muscles that, quadriceps muscles rather, that extend the knee. We'll be working primarily with long strokes that go from the attachments to the knee to the attachments to the hip. And again, changing our orientation for a complete release. And so we'll go all the way out to the areas that we're working with the patient in the sideline posture, the iliotibial band, in order to get a complete release of the upper thigh. Knees are an area where there's a great deal of stress and often pain from overuse. One of the things to consider is the tissue attachments around the periphery of the patella or the kneecap. The extensor muscles attach all around the top 180 degrees of the kneecap. Fascial structures, connective tissue structures, attach laterally, and at the inferior part of the patella is the tendon that attaches the muscles of the thigh to the tibia and allows for the extension of the knee. So we're going to be using the PainEraser all the way around the patella, and frequently in this infrapatellar tendon area. One of the things that we want to be very careful of when we're working in this area and the lower leg around the tibia is that we're working in bony areas. And when we're working in bony areas, we want to be really careful to let the machine do the work. The pressure is not going to be much more than the weight of the machine, and you'll just primarily be using your hands to guide the machine. So we'll be doing a release in this manner, and then we'll have our patient kind of rotate the leg, and this exposes what's called the pes anserine. The pes anserine is just at the medial part of the superior tibia, the big bone of the lower leg, and it's where the long adductors and flexors of the knee attach. And this is an area that's frequently very, very tender for people, and it's an area that we want to pay attention to in releasing the leg and use the PainEraser in this manner in that area, perhaps going up into the muscle belly of these long adductors and flexors of the knee. Okay. The next thing that we want to consider are shin splints, and shin splints are a common problem, especially in athletes. The anatomy here is that we have the tibia, the big bone of the lower leg, and if we just feel the top of the calf, the lower leg in this position, what we'll see is that there's a ridge of bone. You can feel that ridge of bone. That's the tibia. There's a plateau of the tibia, a flat part of the tibia where there is no muscle over the top. And lateral to that is where we find this big muscle called the tibialis anterior. And this is a muscle that pretty much does this action. In fact, this big tendon right here that I'm pointing to is the tibialis anterior tendon. And so this is the action that it does. And it becomes involved at heel strike when we're running or we're walking. And so it's subject to a lot of use and abuse. And so this is a muscle that we'll want to pay attention to, and we'll want to release it in this manner, going from its attachment and the lateral aspect of the inferior knee all the way down to the ankle, and again changing the orientation of our PainEraser to get a more complete release. How long would we work on an area like this? Probably not more than 2 minutes. How long would we work on, let's say, this region? Maybe 2 or 3 minutes. One of the things that we want to be careful about is not overdoing it, realizing that this is a really powerful treatment, it's a very efficient treatment, and we don't want to use excessive pressure or excessive amounts of time to release that. When we had Esther laying face down, just think about this area from here to here that we saw up the back. That might be 5 minutes of work. The area of the pelvis and lower back, that might be 3, 4, perhaps 5 minutes if we are really doing a lot of work, but really no longer than that. The foot and ankle obviously get a lot of stress and strain carrying us around, and there are a few conditions of the ankle that we want to think about. There are 2 types of sprains primarily for the ankle. One is called an eversion sprain, and that's when the foot does this and the ligaments and muscles on the outside of the ankle and the calf become strained. This is the most common sprain type injury for the ankle. The inversion sprain is just the opposite, and just because of the anatomy of the body and the fact that these ligaments on the inside of the ankle are just so strong and robust, this is a much less common kind of injury to the ankle. When we're using the PainEraser on the ankle, and I think if we can kind of rotate like this a little bit, we'll see better, we're going to look at this bump of bone. This is called the medial malleolus. It's an attachment point for many of the ligaments then that go into the foot and stabilize the ankle. So we'll be working below, in front of, and in back of that medial malleolus. And that allows us to work on most of the ligament attachments here. And also, we'll be working on some of these muscles on the medial aspect of the calf, because in an inversion strain, some of these tissues are going to be strained as well. So we'll want to give them some relief by using the PainEraser in this way. The eversion sprain is going to, I think maybe we'll do better actually if we use your other foot. So on the eversion sprain, we're going to be, this is the lateral malleolus, and it is the attachment point for ligaments that go into the foot. And so we're going to want to use the PainEraser in this way, perhaps even using the small head very, very lightly to get into these particular ligaments. And these perineal muscles on the outside of the calf are often injured in this kind of a sprain injury. So we'll want to be working the perineal muscles all the way from this lateral aspect of the knee down to the ankle in this manner, turning the device so that we get a more complete release. And finally, should we go back to this one? And maybe have you turn your knee out. And we want to consider here Achilles tendonitis. So this is also a very common problem, and one in which we'll be using the device not only on the tendon that goes from the calcaneus or heel bone to about here, but also the musculotendinous junction, this kind of hybrid of tendon and muscle below the big bulge of muscle of the calf. And so again, we'll be working in this way getting both sides, getting the back, the medial side of that tendon, working up into the musculotendinous junction, and a bit perhaps up into the muscle itself, and then changing the orientation of the device so that we get a more complete release. And finally, let's talk about the bottom of the foot. The bottom of the foot is subject to a couple of problems. One of those is called calcaneal bursitis. It's often referred to as a bone spur. And the bone spur may or may not be there, and it may or may not have much to do with the pain. People who have bone spurs that show up on x-ray often have pain in this area. People without bone spurs on the heel bone often have pain in this area, and people who have bone spurs on x-ray often don't have pain in this area. So let's just say that the pain that we have around the heel may or may not have anything to do with the heel spur, and typically you'll see that you get a good relief of pain by releasing the soft tissues. So we'll be using the PainEraser in this manner, going all the way around from the medial to the lateral aspect of the heel, over the back edge of the heel, and really focusing on this area here, the medial aspect, where muscles and ligaments attach to the calcaneus bone. Sometimes the tightness and irritation that happens here at the heel is more broadly distributed, and we would call that a plantar fasciitis. There's a lot of connective tissue that holds the bottom of the foot in position, and it can become quite tight and quite painful. And in this case, we'll go all the way from the heel to the ball of the foot, or the metatarsal heads, in this way, going all the way out here, all the way here, and changing the orientation of the device to get a complete release. And finally, there may be pain and irritation, tightness in the tissues overlying the metatarsal heads, or the ball of the foot. And in this case, we'll use the PainEraser in this manner. Changing the orientation of the device. And we may also use the small head to get into the spaces between the toes, between the metatarsal bones. And when we do this, of course, we're going to use very, very little pressure, and yet let the movement of the device do the work for us. The extensors of the toes is here on the lateral and dorsal aspect of the foot, and this is a muscle that may become very painful, very tight. And here again, we'll use the PainEraser very lightly because we're over a bony area, and we'll cover this whole region up to this first ray. And again, we'll change the orientation of the device to get a complete release. Okay. I think that covers just about everything. So Esther, thank you for allowing us to demonstrate with you. And just a few words. One is, let the device do the work. Don't use excessive pressure. Don't use excessive time. And if you have any questions about the use of the PainEraser, be sure to contact us by email. You'll find our web address at the PainEraser.com website. And we look forward to hearing from you. Thank you.